All right, good morning. We're going to cover chapter 2 in covering the pharmacokinetics, pharmacodynamics, and the pharmacogenetics. And so we want to know that once the drug is administered, it goes through two phases, the pharmacokinetic phase and the pharmacodynamic phase. We have the pharmacokinetic phase describes the movement of the drug through the body, and the pharmacokinetic is composed of 4 processes: the absorption, distribution, metabolism, and excretion. Now, drug absorption is a movement of the drug through the bloodstream after the administration. So you'll have the different drug phases, and so therefore you'll see different drugs are absorbed in different areas. So we'll talk about that. And so for the body, it is utilized drug taken orally. A drug is solid in a solid form, must disintegrate or break into pieces and in the stomach, and then it's usually absorbed in the first area of the small intestine. So you'll have with liquid form of solution, you'll see that breakdown is absorbed more quickly, and so the process of dissolution, this enables the drug to be absorbed from the gastrointestinal tract into the bloodstream. So we're going to go into a little further information on the drug absorption and the breakdown and the dissolution. And so really you'll see that the absorption methods, you want to focus on the passive transport with a diffusion and how it facilitates the diffusion, and then with the active transport with energy, and then the pinocytosis, the cell carries a drug across the membrane by engulfing the drug particles. So with with the absorption across the mucosal lining into the small intestine occurs through passive transport, active transport, and then the pinocytosis. The passive transport occurs through 2 processes: diffusion and facilitated diffusion. As you can see, in passive transport and diffusion, drugs move across the cell membrane from the area to, of course, from the higher concentration to the lower concentration. And then you have the facilitated diffusion, relies on a carrier protein, moves the drug from an area of higher concentration to the area of lower concentration. So you want to make sure with active transport, it requires a carrier, or such like an enzyme or a protein, to move the drug against a concentrated gradient, which the ATP, which is the energy, is required for that active transport absorption. And with pinocytosis, it's a process which the cell carries a drug across the membrane by engulfing the drug particles in a vesicle. Now, the mucosal membrane, which lines the GI tract, usually the villi, that is composed of lipids and protein, lipid-soluble drugs, and able to pass rapidly through the membrane. Water-soluble drugs, on the other hand, need a carrier, either an enzyme or a protein, and to pass through the mucous membrane. Large particles are able to pass through the mucous membrane if they are non-ionized, basically having no positive or negative charge. Now, the large particles are able to pass through and then sometimes absorb in the duodenum, depending on the health of the individual. So you will see people that have had the gastric sleeve. They say that, oh, they don't need to have more of a liquid form of vitamins and nutrients. They usually can be broken down, but it is always best to go with the type of gel type or the gummy that's readily absorbed instead of the hard capsulated, so it won't just pass through and cause the elac, what they call it, where it doesn't break it down. You'll see it actually pass through the gastric system entirely. Now you can look at this diagram and see it, how it explains the different processes with diffusion, facilitated diffusion, and then you see here where the ATP comes into place to help break down in the active transport. Okay, in pharmacokinetics, affecting absorption is blood circulation, pain, stress, food texture, and the way the fat content, temperature, pH, route of administration, drug movement in the GI tract to the liver via portal vein, first pass effect, and the bioavailability. So here you see with this, we also look at the factors affecting the bioavailability, the drug form, route of administration, the gastric mucosa, and the motility and administration with food and other drugs, say fat-soluble medications or fat-soluble vitamins have to be taken with food or they won't metabolize. Changes in the liver metabolism, say older or even younger children, like we spoke in the last chapter, will absorb their medication differently than a young adult. So keep that in mind. Now, drug distribution, protein binding, free drugs, and then the volume of the drug distribution. And so we will see that the route of administration, say for instance, insulin, growth hormones, or other protein-based drugs are destroyed in the small intestine. So that's why that most of the time you'll see that as an injection. Now the digestive enzyme has to be given orally. So You'll see in the liver, some drugs are metabolized in an inactive form and is excreted, thus, depending on the amount of the active drug available to exert the pharmacological effect. That is referred to the first pass effect. Now, bioavailability, you'll see is refers to the percentage of the drug available for activity. So that does make a difference in the filler that we would talk about in the inert ingredients. Now, let's see. You can see here, study those diagrams. With this being with the pharmacokinetics here, you can actually see it, the distribution. And some drugs that do cross the blood-brain barrier, which means via the brain, or actually in, say, pregnancy, actually if it would pass through to the placenta and to the fetus. With drug metabolism, you're looking at the biotransformation. We're talking about half-life. You really see that when you're talking about insulin. And then when we're talking about loading dose, usually that's an indicator, whether it be, usually in the hospital setting, you'll see it be talking about a antibiotic. And sometimes in psychotropic meds, they'll have a loading dose, depending on the case scenario. Drug excretion and elimination, you'll see different things metabolized differently. Some things do metabolize through the kidneys. So you'll look at that creatinine clearance bun and glomerular filtration rate. Some are, you'll see it, which I like to say, it affects the liver. It basically is metabolized through the liver. And then you'll see changes in feces. Say if you're taking iron, you'll see a change in the color of the feces, and then you actually see some, changes in the lung, and then saliva, sweat, and breast milk. When we say saliva, some drugs will actually dry the mouth out, and then some medications that basically promote the fight or flight will sometimes, you'll see the patient initially, until they become accustomed to it, have more a sweat output. And then we're looking at what drugs actually cross through into the breast milk that we want to avoid. Now, pharmacodynamics is a study of the way the drugs affect the body, primarily affect the desirable response, and then the secondary effect is the desirable or undesirable response. Now, pharmacodynamics is a study of the effect of drugs on the body. The drugs act within the body to mimic the actions of the body's own chemical messengers. The dose response relationship in the body's psychologic response to the changes of the drug concentration at the site of the action. Now, the potency refers to the amount of the drug needed to elicit the specific psychological response into the drug for the drug. And then the point of which increasing the drug dosage no longer increases the desired therapeutic response is referred to the maximal efficiency. And you will see people that will become more tolerant to medications, especially in pain medications, and they will not reach the desired effect, but they will actually have the maximum efficient actually produce. So if it's not producing or actually relieving, the physician will choose to see if they want to try a different form of medication. Say, for instance, bone cancer, you'll usually see fentanyl patches put into place because at that point you don't have the pain relief you would, and it wouldn't be therapeutic to use just ongoing hydrocodone. So we have the point of increasing the drug, like we said, it was desired response on the maximum efficiency is something that the nurses have to be objective about and really be in a non-judgmental state because of the fact they have the orders from the physician they have to go by because they cannot have a predestined or a predetermined viewpoint on that patient. There is many patients that overuse, but it is not our cultural, it is not our job or our duty to be the judge and jury. So we have to be objective in that case. We can see, and if we feel like that the patient hasn't had a situation before and we need to inform the physician, it is our right to do that, and it is always played out in a professional manner. Now, with the drug response relationship, you're looking at the potency versus the therapeutic index. Say, for instance, the therapeutic index describes a relationship between the therapeutic dose of the drug and the toxic dose of the drug. When, say, an example, ED50 and then the TD50. Say the PO meds, we have the drugs lasting 2 to 3 hours, the most effective state, whereas it has the highest level of therapeutic value, and then whereas you have the IV medication that the onset is sooner, so you have 30 to 60 minutes where you actually have the highest level of therapeutic maximum. And then IM medication is 2 to 4 hours. The drug peaks occur when it reaches the highest concentration in the blood, indicating the rate of absorption, draw peak levels at the appropriate time based on the route. The duration and action and the length of the time of the drug is the therapeutic effect. The trough level, you're looking at, when you're talking trough, usually antibiotics. And so lowest plasma concentration drawn prior to the next dose, just to make sure they're therapeutically sufficient, or they're not building up a toxicity. Now, drugs act as binding receptors, and binding the drugs may activate a receptor producing a response, or it may be inactivated as a receptor blocking a response. As you can see, we were just talking about it in this slide. It shows where that peak and here we're just basically covering the onset, peak, and duration. And you see a lot of this, and you're going to see it in the future. Wanting to know and we had talked about it last semester about insulin and the onset of the insulin with the short acting, peak, and the duration, and versus the long acting. The pharmacodynamics continue. Here we got another diagram showing just a different way on the onset and the peak duration, and how it has a downhill flow, and the time variance here. Most receptors are protein in nature. We have found in cell membranes, there are 4 receptor families. We have the cell membrane embedded enzymes. We have the ligand-gated ion channels, and the G protein coupled receptor systems, and the transcription factors. Now you'll see that drugs here that activate receptors produce a desired response and called agonist. Say, for instance, an example is given albuterol to a patient with asthma. Albuterol acts by stimulating the beta receptors and then causing the bronchodilation. Drugs that prevent the receptor activation and block a response is called antagonist. So you basically you would look up in your medical terminology, and you're looking at agonist versus antagonist. Now, drugs that have multi-receptor sites are considered non-specific drugs that affect multiple receptors, and they're considered non-selective. Mechanisms, now drug, you look like basically a key. Drug binds a receptor, and then drug B cannot bind to a receptor. The drug action includes stimulation, depression, irritation, replacement, cytotoxic action, antimicrobial action, modification of immune status. Now you can see the different receptor families here. It shows a good transcription of what, or diagram, to try to make you understand a little bit better and how it binds. And we had just gone over the antagonist and the agonist. Oh, this is a good diagram here. It really, when you're talking about different things that are cholinergic response sites, and how you can actually see different drugs and how they will reflect, and how you can see how it affects the pupils, and how the blood vessels is going to constrict or dilate, and that means even with a pupil. Usually with a stimulant, you'll see the pupils will dilate to let more light in, because it gives a response, basically mocking a fight or flight, whereas the depressants will actually do work on the parasympathetic and do constrict, and it will actually relax. And you will think that by relaxing it would do the opposite, but actually you'll see the pupils go back to the normal size, and you'll see the stomach. It will say the parasympathetic, and it would actually work on the smooth muscles opposed to causing more activity and stimulating. And then where bronchodilator, say, it would actually work on dilating the bronchi, and then you'll have your bladder, your smooth muscle relax for spasms in the bladder, or you can actually have some, if they have issues with emptying the bladder, that will actually cause contraction. We have to look at the drug therapy and the side effects, and you want to look at adverse reactions in the intentional, unexpected reactions of drug therapy that will occur in normal drug doses. And we have to look at the drug toxicity occurs when the drug levels exceed the therapeutic range. Toxicity may occur secondary to overdose, intentional or unintentional. You'll see a lot of the people that are in the media that have gone to rehab, and they have been a heroin addict, and they have built up a tolerance, and so they've gone away from using the drug, and you see usually they come out and they use that same dose that they had used before, and they don't survive. They don't have access to Narcan, and so normally it happens so fast that that's when you usually see that. They don't have the tolerance anymore. Always know the meds you're giving, and you know the side effects and the adverse effects that could occur. Like I talked to you about last chapter, you want to know more than the patient does, especially with what they have access to, and you want to let them realize how the benefits outweigh the risk. And they have to state the risk that are involved. But if those patients have underlying liver issues and that medication could affect the liver, you want to make sure that they know that they're taking a risk, and that the doctor is reinforced, and that they have told you, because some doctors don't communicate with other doctors. You have so many physicians now that are gastro doctors, the primary care physician. They have so many specialties that you would not believe how many um, things that the primary physician has not learned from the specialist, because the specialist hadn't sent over the information, and the patient may assume that they already know that, and they don't, and then therefore they give them a medication that may cause them more harm than good. Now, genetic factors can also alter drug metabolism, resulting in either enhanced or diminished drug response. And they have found that people that are usually redheads, they have a natural, just a genetic trait, a tolerance for some medications and sensitivities to others. Now, the placebo effect and the drug response is attributed to the chemical properties of a drug. The response of the positive and negative influences, beliefs, attitudes, and expectations of the patient. You see all these mechanisms, how the drugs of the drug action, and how the cholinergic and how it suppresses depending on the medication. Now, in this chapter, I have made y'all terminology cards that y'all want to utilize for study. I want y'all to know those. And with the guided reading, just go over and listen to the recording again and fill it out if you need to. Now, with the food may increase or decrease the delay of the body's pharmacokinetic response to drugs. Say, for instance, grapefruit alters the metabolism of many different drugs. You really just shy away if you're on medications from grapefruit juice, because unless you want to just look up every drug, you got to look CPRO. You need to have a 2-hour window, or you can take it 1 hour after antacid during a product of different, like milk. You have that you have to look at. There's some medications you have to take on an empty stomach. So that is key. You have to know your drugs and all of the side effects. The drugs often interfere with the clinical laboratory testing by cross reactions with antibodies. Like if you go in with an infection and they draw blood cultures, you will not want to have had any antibiotics whatsoever, because it will totally interfere with any type of culture that they may be trying to get on you. Because there's one thing as a nurse you make sure of: before you give that first dose of antibiotic, make sure you have those cultures already drawn. And because if you haven't, you've just totally nullified the things that the cultures are there for. You won't get an accurate baseline. So you want to know what that microorganism is either resistant to or sensitive to. So always remember that, especially with you're dealing with PD. You make sure that is very important. Now we have drugs that induce photosensitivity. With the like tetracycline, take tetracycline, you're going to sunburn easy. It is cause over interaction of the drug exposure to the UVA light. So just basically know your terms, your objectives, the different metabolisms of the drugs, the side effects, adverse reactions, the drug toxicity, and how right here with the biological variations of how people are tolerant, and how they basically can respond to some medication, and then also like in studies on the psychological placebo effect, drug interactions, pharmacokinetic interactions, all these things we've talked about. Now, the different medications that are highly addictive, and you want to make sure you know the history of that patient. If they have that gene that they have a sensitivity to become chemically dependent, you want to offer alternative medications first, and usually Tylenol or Motrin will be offered in that situation. If the physician most likely will already know about the situation, but if all possible, always use the lowest level of pain medication possible in that situation. And you have the synergistic and the antagonistic. And like we talked about, the interaction with food, drug laboratory with the culture, drug-induced photosensitivity. We already talked about that. We want to make sure you want to have a practice question here. Patient has a liver kidney disease. He's given a medication with a half-life of 30 hours. And the nurse expects the duration of this medication to, it would be decreased because of the fact they metabolize at a lower rate. And also, in some sorts, it actually can dissipate if it can totally, some depending on the situation, totally metabolize it so fast in the liver that it won't absorb properly. Look at your practice questions here. Look at these, look these up. And B is the question. answer on that. Okay. Y'all have any questions, let me know. Refer to the syllabus on the times that you can contact me, and unless it's an emergency, you can reach me, and I'll get back with you as soon as possible. All right. Thank you.